So Dr. Gemmete is a professor of radiology and neurosurgery at the University of Michigan. He holds board certifications in diagnostic radiology, neuroradiology, and interventional radiology, and has published hundreds of papers on those topics. Dr. Gemmete has around 20 years of experience in neuro-IR and has very kindly agreed to speak to us about the first pass effect for mechanical thrombectomy. Thank you again, doctor, for your time and your commitment to IR education. We really appreciate it.
Looks like we have 12 people on the lecture. All right, thanks for the invitation. I appreciate the organizing committee giving me the invitation. So today we're going to talk about the first pass effect for mechanical thrombectomy. It's one of the resident webinars. He already introduced. My name is Joseph Gemmete. I'm a professor of radiology and neurosurgery at the University of Michigan. So these are my disclosures. I'm a stockholder in Ablative Solutions, Innovative Cardiovascular Solutions, Calypso, and Neurico, FlexTech, Didenti, Neurofine, consultant for Covidien, and then we have 2 NIH grants. So the objectives of this talk will go over the theory, some of the access issues, the types of thrombi, the first pass effect, and then we'll go over some of the balloon guide catheters, and then the technique for optimization to remove thrombus. So the theory. So there's 2 primary factors that determine how much force is required to remove thrombus. One is the force of impaction, which is a pressure gradient across the thrombus. So it's a systemic pressure proximal to the thrombus minus the pressure from retrograde flow distal to the thrombus. And then there's some combined force of friction and adhesion between the thrombus and the vessel wall. So this little diagram here, you can see that the pressure distal and then the pressure proximal. So this force gradient will determine how well you can remove the thrombus. And then there's friction here with the thrombus against the vessel wall. So there's a decreased rate of thrombus removal when there's a decreased rate of success with the worst collateral. So that makes sense because this pressure here is going to be less, so the pressure gradient is going to be more. Fibrin-rich clot or thrombi with less than 20% RBC content have a higher coefficient of static friction. So the frictional force there is going to be higher, so it's going to be harder to remove it. And then obviously at greatest thrombus length, they're going to have more friction and adhesion, so they're going to have a larger surface area, and it's going to be harder to remove the thrombus. So arterial access. So we usually use a femoral access. We place a 24 cm length 8 to 9 front sheath in the groin, so it'll get you up into the lower abdominal aorta. Lately, what we've been using, we usually use the Penumbra Simmons catheter, which is has a little bit more sturdiness. Through the balloon guide catheter, Walrus balloon guide catheter, and we put this over a glide exchange wire. And with this technique, we really haven't had any problems getting up into the ICA. If you have difficult or tortuous anatomy, you probably want to use a 9 front sheath, a 97, put it 70 cm, put it in the proximal common carotid artery, and then through this you can introduce the balloon guide and nothing will basically herniate. So if you have really tortuous anatomy, I think this technique does help, and then you introduce the balloon guide. This technique also is, I think, useful if you have a balloon guide where you aspirate thrombus and you got to remove the balloon guide. You still have access in the common carotid artery, so then you can easily remove and pull back the balloon guide. You can also do a brachial or radial access. I haven't done any brachial access in a long time, but we've done a number of cases with the radial access. You're basically limited by the size of the artery, so you can usually put a 4 to 6 front sheath. I have put a 7 front sheath on the radial artery. It does cause a little bit more spasm, and there is a learning curve. So we pretty much do all our diagnostic outpatient cerebral angiography through the radial approach now. The systems that are currently in use are pretty small to actually pull out thrombus within the IC or M1 segment. And again, there's a learning curve. So you don't want to do this as a first case when you're trying to do an acute thrombectomy where time is of the essence. And then you can also do a direct carotid access approach. So we've done this in probably about 15 to 20 patients. You basically want to puncture the common carotid artery just above the level of the clavicle, so you have enough running room. We'll stick it under ultrasound with like a 21 gauge needle. We'll do a road map, and then we'll advance, the 018 wire up into the external carotid artery, followed by the 3/4 dilator, and then put the a Rosen wire, something that's stiff, so the proximal end is stiff, into the external carotid artery, and then either put a 6 front sheath or an 8 front sheath. And initially when I started doing this, I was just putting the aspiration catheter through the sheath, but I don't think this is a good technique because you can actually damage the aspiration catheters. The distal tips are pretty floppy. If the patient's been given IV TPA, theoretically, there is a higher risk of bleeding. So question if you should use a 6 front sheath versus an 8 front sheath. But if you put an 8 front sheath, you can basically put any thrombectomy device you want in through the carotid artery. So now basically what we do is we put 8 front sheath in a short one, like a 12 cm, and then through this, I'll put the balloon guide. So the balloon guide's pretty long. It's 90 cm to 100 cm, or a Neuromax sheath, which is 90 to 100 cm up into the IC. And then you have the sheath laying outside the body, so you can actually lay it out over the belly. And it's almost right where you'll access the common femoral. And then you basically can introduce any aspiration catheter or stent retriever you want. And then I have just held direct pressure on the carotid. If the patient's been given, IV TPA, we'll usually do an angioseal, 6 to 8 French angioseal, depending on the size of the sheath. And we'll usually deploy this under ultrasound so that we can see that the plug, is opposed up against the vessel wall, and then the collagen plug comes down where the hole is where we punctured the artery. So I think this is a good technique. It's very fast. There are coming out with devices now that you can afford direct carotid access, and hopefully those will be out on the market in about a year. So when you're doing a thrombectomy, the time is very important. Some of the goals: arrival of CT to groin puncture, you want to have less than 30 minutes. Puncture to revascularization, less than 30 minutes. So you want to have the door to revascularization time less than 60 minutes. That's our goal, and usually we can succeed in that goal. We have a well-oiled machine where the place I'm at, and we can usually get the door to revascularization in less than 60 minutes. But you need to have a really, really good team. So the composition of the thrombi. So thrombi are made up of a bunch of different things. They're made up of fibrin, RBCs, platelets, neutrophils, von Willebrand factor, and then there's DNA actually in thrombi. So it's not just RBCs held together. This is a little diagram. This was a paper taken from Hematological in 2020. Is a pretty interesting diagram, paper about the composition of thrombi. So it's composed of RBCs here. There's fibrin between the RBCs. There's actually neutrophils within the thrombin, platelets. And then there's these neutrophil netosis, von Willebrand factor, and then fibrin. So this is all composed of a clot that you're going to pull out from the intracranial circulation. This is just staining here from the same paper. You can see, let me move this over. H&E stain, MSB stain, and a platelet stain. So there are certain thrombus that are rich in RBCs. So the H&E shows that this one is rich in RBCs, where there's minimal platelets here. Where the one that's stained with platelets here, you can see that there's a lot of platelets in this one. And then there's in between here where there's a composition of RBCs and platelets. This little diagram, again, taken from the paper here. So the percentage of thrombus, some of them are very platelet rich, where they're 100% platelets, and then the other ones are almost completely RBC rich. And this is important a little bit later in the talk. So the composition is important, the etiology. So if it's fresh thrombus, it's usually from the carotid. If it's more organized thrombus or embolus, it's usually more from the heart. It's usually more fibrin, platelet, more organized. Some of the radiological signs that you can see on a non-contrast CT or CTA, if it's low attenuation, it's more probably fibrin, platelet rich. If it's higher attenuation, it's more RBC rich. And this has a fact, and some people think that if it's more RBCs, it's more likely to respond to IV TPA, or if it's more platelet, it's more resistant to IV TPA. And then people are developing, they're looking at all new different targets to try and lyse clot by giving drugs through the IV. And I think this accounts for some of the thrombectomy failures, that the thrombi are not just RBCs, they're composed of a bunch of different things, and there's probably a bunch of different pathways which we need to go after if we're going to try and lyse the clot from an IV approach. So the response to TPA or thrombectomy, the RBC-rich clots usually respond well to thrombectomy or IV TPA, or a fresh RBC clot with some fresh fibrin. Usually responds well to IVTPA or thrombectomy. The ones that are resistant to IVTPA or thrombectomy are the the platelet ones, the dense fibrin, the ones that have a lot of von Willebrand factor, DNA, neutrophils. So the clot resistance, there's a number of different factors that people think why you can't pull out the clot. Just because the clot has a heterogeneous composition. So if it's, it's strictly RBCs, it usually comes out in the first pass. It's very, very easy to pull out. And then there's other clots that you'll see where you might make 3 or 4 passes and you might not be able to get the clot out. And those are usually more platelet rich. Some of them might have a little bit of calcification in them. And then other people are looking at, depending on how long the brain's been dead, there theoretically could be a reperfusion injury where the brain actually doesn't want to revascularize itself, where it activates von Willebrand factor and these neutrophil extracellular traps, which prevent you from actually revascularizing the brain because the brain is already dead. It doesn't want any more blood. And people are working on some of these. So the atomase S13 and the DNase. So the DNase is for the DNase and the DNA seen in the clot. And then the atom TS13 is a substance that's, I don't think it's in trial, that's looking at the neutrophil traps to try and lyse these neutrophil traps. So the other thing with thrombi composition and impact to retrieval, so fresh RBC clots are less organized. When you're doing a thrombectomy, they're more prone to fragmentation and distal embolization. Fibrin-rich clots, they're less likely to deform, so you probably need a very large guide catheter or suction catheter to get those out because they aren't going to deform into the catheter. They're also more difficult to grab, so you can't get integration of the stent retriever with the fibrin-rich clots. So these can be very difficult to pull out. And then for each thrombectomy attempt, the clot becomes further compacted and it becomes more sticky, making removal a lot more difficult. So this is a little diagram here taken from the Journal of Stroke in 2017. You can see here as you increase the number of attempts at thrombectomy, the clot becomes more compressed here. On this, you can see how it becomes more compressed with more attempts at retrieval. And when it becomes more compressed, you actually increase the friction here. So it becomes very, very hard to take out. And this is just a little flow diagram where on the initial attempt, you can see that the clot here is very large. And then this is with multiple attempts, you can see that the clot becomes more compacted and compressed, and it's actually harder to get out. So I think this is one of the reasons why if you have to do multiple pulls, it's actually becomes harder to pull out the clot. So that's why I think it's very, very important to try and pull this out with the first pass technique, which I'll go over later. So the questions, given that all clots are different, is there one method that increases the chance of success? I would say yes, and I'll show you that. And then what are the goals in performing the thrombectomy procedure? So I'll go over some of these questions here. So the goals of the thrombectomy procedure, you want to perform the procedure fast. Again, time is brain. You want to try and restore TICI 2C or 3 reperfusion. Those patients definitely have a better outcome. So you want that is your goal, to get TICI 2C or 3. We try TICI 3 now. You want to try and perform one pass. There's a better outcome with a decreased mortality, and I'll show you some of that data. So the first pass effect. So the first pass effect, TICI 2C3 reperfusion, why bother? There's several studies now that have shown better patient outcomes. And there's also one study that showed a decrease in healthcare costs because these patients actually do better. They're able to get out of the ICU a lot quicker and actually be able to they can get home a lot quicker, and they don't require as much rehabilitation to have a modified ranking score of 0 to 2. So the first pass effect, if you look at this diagram, this was published in Stroke in 2018. You can see the top bar here, A, is the first pass effect. They had 89 patients, and then they had 265 patients in the non-first pass effect. You can see that the modified Rankin score of less than 2 was 61% for the first pass effect, so they got the clot out in the first pass effect, versus about 35% for a non-first pass effect, and this was statistically significant. You can also see that the death rate, so modified Rankin score of 6, was 16% with the first pass effect, where it was almost 36% with a non-first pass effect. So this is why it's very important to get out the clot on the first pass. This is another diagram taken from the same article in Stroke in 2018. You can see here, first pass effect at TICI 3 here. This is the first pass effect here in the gray, and this is the non-first pass effect. So you can see that here, 16.3% versus 61%, and then any TICI 3 was 55% versus 25%. And then here, the mortality, you can see that the mortality was actually was higher here versus lower here. I'm sorry. This is first pass effect. Yeah. So the first pass effect here, the modified Rankin score is in gray, and the mortality is here. So the first pass effect, the mortality was less, 16%. Modified Rankin is high, and then any TICI 3, you can see that the modified Rankin score goes down a little bit here, 55%, and the mortality starts to go up. And then once you get TICI 2B, so the reperfusion is a little bit less, you can see that the modified Rankin score also goes down, and then the mortality actually goes up. So it's very important that you open up the vessel on the first pass and you try and obtain a TICI 3 score. This is another slide taken from the RISE 2 trial comparing first pass effect versus non-first pass effect. So the pink here is first pass effect and the orange is non-first pass effect. So the modified Rankin score of less than 1, you can see that it was 63% with the first pass effect versus 47% for the non-first pass effect. Modified Rankin score of 0 to 2, again, was higher with first pass effect, 80% versus 61%. You can see that the 90-day mortality was higher with the non-first pass effect versus the first pass effect, so 6% versus 14%. Also, embolization in new territory was lower if you were able to get the clot out in the first pass effect versus the non-first pass effect. And then for cost, the mean number of stent retrievers was lower. Obviously, with the first pass effect, you're only putting up 1 stent retriever. Or if you're, doing exhaustive measures to try and pull out the thrombus, sometimes you'll pull out another stent retriever or another aspiration catheter, so the cost of the procedure goes up. And then you can see the mean length of stay was less with the first pass effect at 6.1 days versus almost 10 days with the non-first pass effect. So this is why it's very important to try and pull out the clot on the first pass, and you want to optimize that. So the technique, first pass effect, reperfusion, how should you do it? Should you do direct aspiration versus stent retriever versus a combined approach? I'll go over some of the data. Should you go femoral versus radial versus carotid? Should you use a balloon guide versus no balloon guide? And these are some very important technical questions in doing the procedure that I think are very important to take into consideration. So the first pass reperfusion, direct aspiration versus stent retriever versus combined approach. So these are several of the thrombectomy trials that described first pass effect. The ASTER and the COMPASS were primarily just direct aspiration. The ARTIS, SAVE, CAPTIVE, PROTECT Plus were a combination of stent retrievers and aspiration. So you can see that the TICI 3 rate was lower with just doing direct aspiration versus doing some combination approach, a stent retriever with aspiration or a balloon guide with a stent retriever. Some of the studies reported TICI 2C, and you can see that the TICI 2C compared to 2 of these trials, so the COMPASS is direct aspiration, CAPTIVE is a combination approach with a stent retriever and direct aspiration. You can see that the TICI 2C rate is higher, which is very important. You can also see that the TICI 2B is higher within the combination approach, these last 4 trials versus direct aspiration. The ASTER and COMPASS didn't report the first pass effect in their in their trials. But you can see it ranges anywhere from 43% up to 72% with the save. And the first pass effect, it's roughly about 60 to 70%. And then you can see some of these trials, they had to do more than one pass to open it up because obviously they couldn't get it out. You know, the first pass effect was 72% on this one, but it was about 60% in the other ones. And then these are the references here. So, you know, a lot of people are touting direct aspiration because it's cheaper. They think it's faster. You know, I don't know if that is actually a true statement. You know, I don't think these patients, they claim that the Compass and Aster patients had the same outcome, but I don't know if you can really say that. And this was published by McTaggart and Stroke in 2020 here. So first pass reperfusion, should you go femoral versus radial? I think in the age of 2020, I think you should probably go femoral. Just because you can introduce larger suction catheters, larger proximal sheaths. The balloon guide, the current balloon guide we use is very large. It's 8 French. So to get an 8 French balloon guide through the radial artery, I think you're going to cause a lot of spasm. Probably won't make some of the bends in the aortic arch. I think the radial approach does have some use in a posterior circulation stroke where you're coming up to the vertebral artery. If you have a bovine arch, come from the right side, you can get a left common carotid artery very easily. Or if the patient has severe atherosclerotic disease at the aortic arch. So there's certain cases we will use a radial approach. We'll usually look at the CT. We'll usually get, on all the patients, we get a CT of the neck and head, and we pretty much plan like what catheters we're going to use. It gives you a good idea what type of atherosclerotic disease is at the great vessel origins, tortuosity of the common carotid artery, tortuosity of the internal carotid artery, or if there's significant atherosclerotic disease at the carotid bifurcation. So balloon guide catheter. So the first pass effect for reperfusion, balloon guide catheter versus no balloon guide catheter. So the column on the left is with the balloon guide catheter, and the column on the right is without the balloon guide catheter. And these are some of the publications here. So a publication from 2014 up into 2019. So you can see that the TICI-2B percentage of TICI-2B reperfusion, I think you could say, from these trials that it's probably higher with the balloon guide catheter versus using like a large sheath. First pass effect percentage. So again, the left side is a balloon guide catheter and the right side is no balloon guide catheter. You can see that the first pass effect is a little bit higher with the balloon guide catheter versus a sheath. And if you take all these studies together, the 90-day modified Rankin score percentage, you can see here again with the balloon guide catheter that the 90-day modified Rankin score is 0 to 2, so independent is higher with the balloon guide catheter versus just a sheath. The procedure time, if you look at it here with the balloon guide catheter, it's probably a little less with the balloon guide catheter than just using a sheath. And then these are the publications. So, based on, these 6 publications, I think there's data to support using a balloon guide catheter. Some of the old balloon guide catheters were not very good. They wouldn't track that well. They're pretty stiff. The balloon, sometimes it wouldn't oppose the vessel wall that well. You wouldn't get occlusion of the internal carotid artery. The new balloon guide catheters actually track very, very well. I've actually had the balloon guide catheter up in the supraclinoid segment. Probably could have got it up in the M1 segment. I mean, it tracks very, very nicely. The only problem with the new balloon guide is that the proximal support might still not be as good. Sometimes it will herniate at the arch if it's very, very tortuous in a type 3 arch. So, based on the theory here, why should you, this is another reason why you should balloon guide. So it'll reduce the impact force on the thrombus. So it'll reduce this impact force with the balloon guide catheter. It's shown to minimize thrombus fragmentation and distal embolization. So when you pull this out, you have flow rest, and then you have suction on it, so you're less likely to get distal, embolization. But the caveat is, if you do the angiogram, flow rest might not be possible if you have collateral flow with a PCOM artery. And you can actually get pretty significant suction flow reversal with a balloon guide catheter just at the skull base. There's several case reports where you actually can retrieve an intracranial occlusion without actually catheterizing the intracranial middle cerebral artery and pull it out. And I showed you there were several studies where it showed that a balloon guide stent improved revascularization, there were shorter procedural times and better clinical outcomes. So, a lot of people are still, on the fence about using a balloon guide catheter because they think it's going to dissect. When you put up the balloon, it doesn't track as well. I don't think that's the case anymore. I think the new balloon guide catheter on the market is a very good balloon guide catheter. The balloon that you inflate is a very soft, compliant balloon. I've only had one case where we caused a small dissection, but it wasn't flow limiting. This is another very important diagram. So the catheter diameter in relation to the clot and the vessel diameter. To pull out a clot, if it's like, pinned up against the vessel wall, you want to have, theoretically, if you're just using direct aspiration, you want to have the largest suction catheter within the vessel wall. So there's some people that are going around saying that, if you have a sheath, if you put up the neuron max sheath within the petrous segment or the cavernous segment, it's occlusive to flow. I would say, based on, this diagram here, it's probably not occlusive to flow. So the average, middle cerebral artery diameter is about 3.35 millimeters. Cross-sectional area is 9 millimeters squared. So half the area is occluded by the largest available catheter. So, you aren't occluding, the middle cerebral artery with a lot of these catheters. And you can see this diagram here, some of the available suction catheters. The Sophia 055 has a, cross-sectional area of 1.9 millimeters squared. The Cello 9 French balloon is only, 4.6 millimeters squared. The Penumbra 068, which a lot of people use, the A68 is only 3 millimeters squared. So you're only maybe taking up half of the vessel. So you're going to have flow around the vessel, as you're trying to pull this thrombus into the suction catheter, and you're going to get distal embolization. It's going to start to fragment. So the first pass effect, I think centers are primarily using a combined approach. If you look at the Captive, Save, Protect Plus, Badass, these are all combined approach with a balloon guide, large aspiration catheter, then a stent retriever. So the steps of the combined approach. This is a nice article, which I would highly recommend about the technique. It was published in Stroke in 2020 by the Calgary group. One, like I told you before, you want to use a quad or a triaxial system. So a long sheath, then with a balloon guide catheter, then a large bore distal access catheter, then with a microcatheter. So a diagram here, this diagram in A. So you put, like a 9 French 70 cm in the common carotid artery, put the balloon guide catheter up in the ICA. This is the thrombus within the M1 segment here, extending into the, the proximal supraclinoid segment. Then through the balloon guide, you want to climb through the balloon guide, with a large bore aspiration catheter with a microcatheter through, the clot. Get the microcatheter distal to the clot. We'll usually put like a very tight J on it so we don't go through any perforators. And you want to climb this, proximal large bore aspiration catheter. You don't want to put it yet to the face of the, shoving it through the clot. You're gonna fragment the clot. And you can get distal embolization. This is another important thing. After you get your microcatheter past, the clot here, so like an A, you want to deploy the stent retriever within the inferior division of the middle cerebral artery. You don't want to put it in the superior division of the middle cerebral artery. Superior division of the middle cerebral artery is very, very tortuous. You aren't going to get nice straight vector forces when you're trying to pull out the thrombus. So we always try, our goal is to always, like a M1 segment, MCA bifurcation, we always try and get it in the inferior division. So, and it has, I think, the perf the vessel when you pull the stent retriever through. So again, you want to put it in the inferior division because it's straighter. The vector forces are going to be more straight, so you're going to get a nice pull here. Where here, the vector forces are going to be like this when you try and pull it out. And I think you're more likely to theoretically cause maybe some mild subarachnoid hemorrhage or damage the vessel by putting it in the superior segment here. Another thing which I think is very, very important, you want to place at least 1/3 of the stent past the clot, and you want to push it out with active push deployment with the stent retriever. So you don't want to unsheath the stent retriever. If you just unsheath it, like in A here, the X, it's not going to get incorporated into the thrombus here. So it's going to look like this on your, your spot fluoroscopic image. It's not going to fully incorporate into the thrombus. You want to put a little bit out, and then you want to push it out, and you'll get really good incorporation of the stent retriever with the thrombus. So you want to have it look like this. So you want to have it get incorporated. We'll usually let it sit there for about 4 to 5 minutes to try and get it incorporated. And the reason why you want to put, before people talked about just putting a stent retriever, the thrombus, right in the middle of the stent retriever. I think you want to put a little bit more stent distal to the thrombus, because when you pull back, if any of it fragments, you're going to get, the little bits and pieces on the distal end of the stent retriever. So you're most likely probably going to get less distal embolization. So you're going to get it all. The little diagram where they showed this in seminars in interventional radiology in 2020, where they put the stent retriever more distal to the thrombus, so at least 1/3 of the stent retriever distal to the thrombus. When they pull back, you can see that a portion of the thrombus is on the distal end of the stent retriever here. So then you want to remove the microcatheter, all right? So you want to remove the microcatheter here. So you just have the wire with the stent retriever. This will give you more suction here. So if you just have the microcatheter through the large bore aspiration catheter, you're going to get less suction. So you want to take this out, and then you just have the wire with the stent retriever. So you're going to get more aspiration through the large bore suction catheter. And then what you want to do is, so I'll leave the suction catheter proximal. You don't want to push the suction catheter in. I'll turn this on to suction, and then I'll pull on the stent retriever to, just to have some pinning of it. And then you want to run the large bore aspiration catheter to the face of the clot. And once you get it to the face of the clot, you aren't going to know that you're engaged within the thrombus. And then we'll let it sit there for about 4 to 5 minutes. Sometimes this will clear. If there's a minimum amount of thrombus, sometimes this will clear. It'll get sucked into the suction catheter while you're waiting, and that means most likely the vessel's open. So then we'll wait 4 to 5 minutes, and then what we do is we usually inflate the balloon here in the ICA. I usually try and get the balloon guide at least to the skull base here, right where it makes the Peters bend in a straight segment. I think you want to have the balloon guide in a straight segment so it can fully oppose the vessel wall and be completely occlusive. And then what you want to do is you want to, on the TUI, on the large bore suction catheter, you want to basically lock the stent retriever within it. And then you basically want to pull in one continuous motion. So you want to pull this down in one continuous motion. So you don't want to lose your momentum. You don't want to pull, stop, because you're going to lose your momentum. Then you're most likely, you theoretically could lose some of the thrombus distally, have distal embolization. So you want to pull in one nice uniform continuous motion so that you don't lose your momentum and you can actually get this thing out. So you want to, remove the whole thing as a complex with this under flow arrest here, one continuous motion. And then what we usually do is we'll aspirate this vigorously until we get blood back, clear blood back. And then once we think we've got blood back, it's freely flown back, we'll then deflate the balloon and then we'll do a run. You do not want to do a run with the balloon inflated, because theoretically, if you still have thrombus up here, you have a closed system and you could actually rupture, the supraclinoid segment or the cavernous, distal cavernous segment of the ICA. And I've been in a couple of meetings where people injected with the balloon up in a closed system. They thought they had retrieved the thrombus and they actually ruptured the supraclinoid segment because it was under high pressure. So just make sure you got a lot of blood back, you let the balloon down and inject. So there is a risk of thrombus shearing when you're pulling the stent retriever through the aspiration catheter. So this is the reason why you just want to lock it. So you want to have it, a little bit, depending on how you deploy your stent retriever, you want to have a little bit, within the distal aspiration catheter, and you don't want to pull this in. You do not want to pull this in through the suction catheter because you're just going to shear this off. So a smaller catheter, the clot has to deform more. So if this is very small, the clot has to deform more. So then you have shear resistance here on the suction catheter, and then you have the full force of the pull force of the stent retriever and the vacuum. And with this, sometimes the clot can get pushed out here. So as the clot gets pushed out, you then get a tail on it, and then it can basically fragment. This is if you pull the stent retriever within the guide catheter. So please do not the stent retriever within the large bore aspiration catheter, because you will get distal embolization. So the summary of the key steps in this technique: you want to use a quad or a triaxial system, a distal placement of a long stent retriever in the inferior division of the middle cerebral artery, the M2 segment. You want an active push deployment of the stent retriever. You want to then remove and reload the microcatheter, advance the distal aspiration catheter to the face of the clot so that you don't have flow through it. Let it sit there for 4 to 5 minutes. Inflate the balloon, and then you have aspiration on the balloon guide catheter and the distal aspiration catheter, and then you want to withdraw the whole system in its entirety under aspiration. So I think that's the best technique to try and get out the clot on the first pass. If this technique still does not work, I don't know what you're going to do. The clot is probably dense fibrin and platelets, or it may have some calcification in it. Calcium is very, very difficult to get out of intracranial artery. So, you'll get, if this is very, very dense, the stent retriever is going to sit alongside the clot here, so it's not getting incorporated. So it's going to to pull this out, it's going to be very, very difficult. So in those cases, sometimes you want to try and cork it with this. So you want to try and, if this is on a straight segment, you want to try and cork it into the catheter and then pull it under aspiration. But then again, you're at risk of sending distal embolus. There's a new stent retriever out now by SIR called the Nimbus, made for these clots that are dense fibrin and platelets, where this has a little bit more radial force. It has a larger basket distally, and they think that this type of stent retriever might be able to remove these dense fibrin and platelet-rich clots. So thrombectomy for distal to M2 segments. I mean, none of the revascularization trials actually looked at M2 segments. We usually put a 3 to 4 millimeter stent retrieval distal in the anterior cerebral artery. There's a high revascularization rate with a low rate of complication. So if you're going on like a our retriever is usually fine with a little bit of a distal aspiration catheter. I think if you're going out farther in the MCA or PCA, like in the insula, there's a lot more tortuosities. So I think, with a stent retriever, you're more likely to probably cause, focal subarachnoid hemorrhage, or, you can get ischemia or perforation injury. If I'm going out distally, like in a distal M2 or a distal M or a proximal M3, I usually just put a small aspiration catheter. The burden of the thrombus, the thrombus burden is very, very small, and the vessel's pretty small. Like a 3 max is almost occlusive in that small of a vessel, and you can just usually get that out with simple aspiration. It's disconcerting when you're doing a thrombectomy with a stent retriever, within a distal M2. Um, when you're pulling the stent retriever, you can actually see the whole arterial segment get displaced, and I call that a diaper moment. I mean, it can be unnerving because it can cause a lot of spasm. A lot of times it's usually okay, but it's always a worry in the back of your head. I think the injury, again, with more of a distal clot, is highest in the distal superior MCA branches, given the tortuosity and course along the frontal operculum. If you get distal fragments, you can give IATPA. Less than 10 milligrams intraarterially is shown to be safe, even after you give the patient IV TPA. And there are some, series where people have given IA glyco-2BA3 inhibitors in distal vessels and open up vessels in small series, and that's been shown to be safe. So you're only given maybe 5 to 10 milligrams of like ReaPro or Integralin, not a lot. I think when you're going out farther, I think you're more likely to damage the vessel with a stent retriever. So I think maybe the DAB technique is better because you can get these smaller catheters out farther and you're less likely to pull on the vessel retriever. So in summary, I described some of the theory, described some of the access, so femoral, radial, carotid. We pretty much use femoral. If I can't get up from a femoral, we'll usually, try from a femoral for about 10 minutes. If the carotid, if it's more of a posterior circulation system, coming from the radial, I think can help. You're less likely to herniate into the arch if it's really tortuous anatomy. If there's a bovine arch, I think a right radial approach is probably better. Thrombi composition, I think, the initial CTA, if it's CT and CTA, if it's high attenuation, it's most likely RBC clots. You're probably higher likelihood to get it out versus something that's more lower attenuation. I think it's very important to optimize your first pass effect. From what I've shown, the modified Rankin score is 0 to 2 is significantly better. Is less if you can get out the clot within the first pass effect. Hospital stays less. You're less likely to use additional products, so the cost of the procedure is less. I showed you some of the data with the balloon guide catheters. I think doing some of this based on the theory and some of the studies that have been published, I think using a balloon guide catheter to optimize thrombus removal is very, very important. And then basically we went over the technique, which is a technique I use, which was published in Stroke in 2020 by the Calgary group, and I'd highly recommend you read that paper. It's a very good paper. So this is my email address, gemmete@med.umich.edu. And again, thank you for the organizers for giving me this opportunity. I appreciate it.
Thank you very much, Dr. Gemmete. Now we'll go on to Q&A. I believe Dr. Badakancheri had a question that he mentioned in the chat box. I'm not sure if you can see that, Dr. Gemmete.
Yeah, there's 3 questions in the chat box. He's talking about carotid access. I haven't had, so carotid cases, I think I've held pressure on a number of them. Usually if the patient has been given IV TPA, and you can usually get, if the patient's been given IV TPA, I think it's a little bit more of an issue. I would definitely close it. But if they haven't been given IV TPA, I've held pressure on 6 and 8 French sheaths within a carotid for I usually hold it a little longer, obviously, because you don't want to get a neck hematoma. I'll usually hold for 20 to 25 minutes. And we haven't had an issue yet, but maybe it's because we haven't done enough cases. I mean, I've only done about 20, 25 cases. The angioceal, I think it's very important when you're deploying in the neck to make sure to watch it going under ultrasound so you can see the foot plate in the artery, that it's up against the vessel wall, that it's not free floating in the artery. I think if it's free floating in the artery, you're more likely to probably get thrombus formation on it. But we haven't had any issues. Did it answer his question? Yeah, he said yes. Does anybody else have any questions? Yes, I've used stent retrievers in the body, number of areas. SMA, use similar technique to pull up fresh SMA thrombus. I've used them in the tibial arteries. I've reused them to remove coils. So we lost a coil in like a pulmonary AVM. Embolization was a very large coil. I just put the stent retriever, the coil with the stent retriever and pulled out very, very easily. So I think that's a good technique. If you lose a coil, put a stent retriever and you can easily get it out. I've used a stent retriever to retrieve onyx. So if you have non-target embolization from onyx, onyx is not adhesive. Specific case I remember, we were doing a J&A embolization, and I told a fellow, watch. There was a big Vidian artery coming off the ICA, and sure enough, saw the onyx start to go through there. He stopped the injection, but it was too late. It started going up. It lodged at the MCA bifurcation. We had the patient fully heparinized. I let the onyx set up a little bit so it wouldn't fragment when we pulled it out, and then we got a catheter past the onyx cast and pulled out the onyx chunk with a stent retriever. So you can pull out onyx with a stent retriever. I would let it get, harden a little bit before you do it. Trying to think what else I've used stent retriever. It's a very nice. You can use it in the periphery a lot. I've put it up temporary, like coiling an aneurysm, like gastroduodenal artery aneurysm, splenic artery aneurysm. Put up a stent retriever as a scaffold, and then you can remove it at the end if you don't want to leave any metal behind. Other questions? Yeah, I'm lucky. I'm really lucky. I mean, I'm neuro trained and body trained, so the neuro's got a lot of really good stuff that you guys can use in the body. There's some unbelievable material. I always cringe when everybody uses a 2.8 French prograde catheter to do everything. I think that catheter is too big to do some of the body stuff that we do because it can be occlusive. And some of the neural catheters are actually track a lot better. Yes, I'm living the dream. To do a thrombectomy, first pass, the fastest one I've done, 12 minutes. 10 to 12 minutes. It was funny because I think two of our fellows were out. I brought the patient down, got access, got up there really fast as anesthesia basically was intubating the patient. We're lucky we got anesthesia with us. They're on our stroke code. So they can intubate the patient really fast for us. They're in the same room. So we're getting access as they're intubating the patient. We're up really fast. They had the clot out. And then I called neurology and they weren't in the room. They came down to evaluate the patient. They asked me like, you're already done? Where's the patient? I'm like, yeah, the patient's already up in the ICU. I already signed the patient out, but the patient's done. We're done. And they're like, no, you aren't. I'm like, yes, we are. So lately, with the balloon guide catheter, I'm trying to think the last case where it was multiple passes. I think the last 12 cases I've done have been all first pass. The last case where we had to do multiple passes, there was a little bit of calcification in there, and I didn't think we were going to get it out. It wasn't completely like, it was just a small bit of calcification. It wasn't like completely around the entire circumference of the artery. So we were able to get a catheter past it, and we were actually able to finally get some of it on the stent retriever and like grasp it and pull it towards the stent retriever and then pull it out under aspiration. But I don't know if anybody's tried to pull out calcium out of the intracranial circulation. If it's a large chunk and it's basically occluding the artery, so it's basically taking up the whole cross-sectional area of the artery, it's almost impossible to pull out. Because you can't get any of it actually inside the aspiration catheter because it's very, very hard. Any other questions? Again, thank you for the opportunity. I appreciate it. If there's no other questions, I think it's 9 o'clock.
Thank you very much, Dr. Gemmete. That was a great presentation.
All right. Thank you. I appreciate it.